I wanted to round off this last subject because it is the most important subject in the oral medicine world of dentistry, and that is this precancer business. I mentioned earlier that we're in the world of gadgets and devices, and a bunch of this has been applied to dentistry. So I thought I'd at least give you a short review so that you are aware of what's out there and sort of what I at least think of the value of that. I just call it dentistry's new gadgets. There are a lot of new gadgets in dentistry. This is just those gadgets that are related to this particular world. What we're trying to do, and not so much myself, I'm just sort of following along a little bit rather than being an originator of this, and that is to try to figure out what is going on down here. In the United States, the pap smear was very popular among dentists in the 1960s. And it was popular as a GYN or gynecological tool in the 1950s for the first time. So we started using it in the 60s for the same reason. But we were scraping all these white lesions, and all we ever got was this keratin on the surface. We never really found any bad cells. And that's, of course, very simple to figure out. We're only scraping the top. The bad cells are down here. The only time we would find something was when the bad cells get all the way to the top. And that should be much more obvious because that is a red lesion. So the question that many people have been asking since about the mid-1990s is, how do we find out what's going on here before we do a biopsy? And in some people's or some circles, that is called, well, in vivo, I guess, lab work. In other words, you're going to be doing my lab work in your office. And I don't think it might be another decade, but I think it's going to happen. There will be tools, little microscopes even, that you will be able to use in your office to put over an area that looks a little suspicious and look at the cells at the bottom of the epithelium. And then you have to decide whether those nuclei are too big or too dark, and I don't have to get involved because that's a really confusing part of my business. So I've seen it already in Rice University in Houston. They're the leaders in that field, working with MD Anderson Cancer Center also in Houston. So, but before we get into that, let's get a little bit of a review. That's what we're trying to do, at least. Find out from out here in the operatory or in the office what's going on down here. And of course, we know that as we progress more toward the right, your right, then we are going to have a higher risk of malignancy. And of course, we have already invasion when we get to the far right. The risk of something, if you get a biopsy that I call mild dysplasia or early dysplasia, they use this terminology, that by definition means the bad cells are in the lower 1/3 only. Moderate, the cells are up in the middle of the epithelium. Severe, they're up in the upper 1/3. So we're really only going by location. There are a few other little kinky twists that we use to make up this number or this terminology. And then, of course, this word carcinoma in situ is cancer in place. And we don't see that very much, but that is when we have dysplastic or immature cells going all the way up to the top. There is a very strong move now to just lump all the severe dysplasias and carcinoma in situ, these last two categories, into one biological behavior, and I think that's a legitimate thing to do. So we don't usually recommend much treatment for mild, or if anything, just sort of follow. Moderate, there are some studies that say we've got about a 15% chance of going on to cancer. When we get into the severe or the carcinoma in situ, then we're up really close to about 1/3 chance of going on to cancer. These are pretty iffy numbers, but they're the best we've got. And the numbers can vary by as much as 15% even, depending on which study you're using. All of these studies for the oral precancers were done back in the 60s and 70s. We're redoing them finally Over the past 5-7 years, we've started doing that. New follow-up studies, especially looking at all these markers, these little cell molecules that will tell us if we see this particular molecule, then we follow the patient. People with this molecule will have a higher risk of anybody of going on to cancer. And that's what a lot of the precancer research is. They're trying to find that one magic molecule that will be the key. And if we see that, we know that this is really a bad cell. Right now, if you look at the overall leukoplakia picture, and leukoplakia is almost 90% of all the precancers that occur in the mouth. If you look at that, it's a 3 or 4% risk. That's what you can tell your patient. No matter what it looks like, you've got a 3 or 4% risk of going on to cancer. And then if you have these different clinical changes I've told you about, then the risk goes up. And then if you have biopsies that show something higher, then the risk is even higher yet. Well, how do we know that something is a dysplastic lesion or something is a precancer? Well, we find a bunch of dysplasia. This was a population study. It's the only one that's looked at oral or head and neck dysplasia, actually. And we found some dysplasia, severe dysplasia in a bunch of people, moderate dysplasia in a bunch of people. Overall, we found atypical cells in about 15% of the biopsies that were done. This, I'd love to say, is the population picture, at least for a European population in the United States, but I can't because these are all diagnosed by physicians, not dentists. And so I don't know what makes a physician look at a white patch in the mouth and say, this is suspicious. I'm sure that dentists pick up many, many more. So I'm assuming that this is, the physicians are picking out sort of the biggest or the ugliest or something more on the severe side, but I don't know that for sure. Well, if we're going to look for dysplastic cells, then we need something. And for 30 years now, maybe close to 40 now, we have had something. There are certain blue dyes. You've all seen the pink and blue stains that I use. H&E is the classic for labs around the world. But before we had the H&E, we were trying different blue stains for nuclei, and Toluidine blue was one of them. Methylene blue, we have several stains. They have, because the nuclei in dysplastic epithelium are large, there's more DNA in them, they may be twice as large as normal. And even if they're not very large, they're darker because there's more DNA. And this stuff stains the DNA. So it makes sense. Let's use this, put it in the mouth where we see a little bit of irregularity and see if anything sticks, because that is actually staining your patient while the patient is alive. Instead of biopsying it, sending it to my lab, and having me process it in the lab, you're doing it in your office. This was the very beginning of that in vivo kind of lab work that I mentioned. A few problems. We had a lot of false positives because, as it turns out, inflamed tissue nuclei also are large because there's increased regeneration, duplication of the cells, production of new cells. And so that is not very good to have a test that is blue a lot, and then when you biopsy, it turns out not to be dysplasia. The downside actually came for two reasons. Number one, you have to clear off all the protein that's kind of coating the mucous membrane, and so you have to swish vinegar for about a minute in the mouth. Patients don't like to swish vinegar for a minute in the mouth. And then you put this dye in, and then look at what you see and kind of point out in your chart where the blue spots are, but you can't do that until you go through a minute of vinegar swishing again to get rid of any surface proteins. So they have to go through this vinegar business twice. And then if you see something positive, here we have a couple of blue spots. The idea is this is where we've got cells with large nuclei or lots of DNA, and they're close enough to the surface to be picked up by this stain. Maybe this doesn't happen if you have cells that are only bad at the bottom. I suspect that's the case. But the problem is then we have all these false positives. Somebody chomps down on their cheek, and you've got an area that will hold the Toluidine blue. So you have to have the patient back in a couple of weeks and repeat the test. And if it's positive then, you go in and biopsy these. And this actually was an area of dysplasia, 2 areas of dysplasia. But that's nice. These are close together. They could be incorporated in one biopsy, but still, if they were widely apart, then you would have done 2 biopsies instead of 1, because you know there's something suspicious about these cells. This has been used in Europe and in Canada for a long, long time, but we have this thing called the FDA, and the FDA has always got politicians telling it what to do and people telling it what to do, and it's kind of like an American football. It's always being tossed hither and yon, and it's going through kind of a bad stretch right now, but the reason they have not allowed it until recently was because if you look on my bottle of Toluidine blue, the one I buy for the lab, it says, caution, this is a carcinogen. You don't see that on a bottle that goes to your office. So you're using a carcinogen to help you find cancer. And you know, the logic kind of escapes people, but really it's only a carcinogen if you use it many, many times, hundreds and hundreds of times. And it's not been shown to be a carcinogen in human trials anyway. So the FDA did approve it about 3 or 4 years ago for use in the United States. And it is a test that works. You have to know how to work the test, and you have to know how to interpret the test, and you have to know what to do with the positive tests. And it has a certain number of false negatives, so you still have to follow the patient and evaluate the lesion without any kind of extra color. So you have to use your head. I'm always saying that. You've got to, no matter what kind of test we have for identifying these abnormal cells, the real test is how your brain functions. You've got to be able to think this process through. And, but this, I think, is not a bad test. It's not very popular anymore. I don't think it'll ever catch on because of the technical difficulties and this large rate of false negatives and false positives. But if we look at a lesion like this, I've already told you that multiple lesions, large lesions, that's PVL. So we know just from that this has a very high risk. So we don't really need any other tests. But where do you do the biopsy? Would Toluidine blue help to identify some problem in this? I think it would, because we've got areas that are totally or completely surrounded, or red patches, pink patches, and that's where you would go normally to try to do your biopsy. Toluidine blue might find an area that has the cells close to the surface. So I think it would have worked on a lesion like this. And one of the things I didn't mention with leukoplakia is, of all the odd things, in certain sites, it has a higher risk. And this is the high-risk site. Ventral tongue and oral floor. You take a leukoplakia of the buccal mucosa and put the exact same lesion on the oral floor, and you've gone up quadruple, maybe 5 or 6 times. The risk has gone up that high. We don't know why. We think it has to do with smokers, at least the carcinogens are in their saliva. The saliva pools in the oral floor, and maybe that's the reason. We really don't know. But this was so, the location alone, regardless of what a lesion looked like, the location alone was enough of a concern in England that for 40 years, the Brits have called this sublingual keratosis. And that is still in the leukoplakia category, and it's got a risk of 40 to 50% chance of going on to cancer. They've recently dropped that terminology and have gone along with the WHO terminology, which is essentially what I just told you about. So we're just looking for cells that can really pick up on some kind of nuclear change. And we can't scrape the top. We can't. If you have a red lesion, that's fine, because you know there's no keratin on there to prevent the abnormal cells from being scraped off. So red lesions, we get scraped. We get a lot of scrapes. We get 2 or 3 cytologies every week in our biopsy service. But almost always, they're looking for candida. They're not looking for a precancer. So cytology isn't so great, but we have a technique that tried to overcome the cytology. It was very popular in the 90s and even first half of the last decade. This was taking cytology, again, a very logical way of changing something to make it useful. This is a pap smear. This is what pap smear would look like. These happen to be GYN cells, but this is a good one, and this is a bad one. You see how much larger the nuclei are, and you see how abnormal they are. And we get all kinds of odd shapes, and you may even find a mitotic figure, but it's not in that particular thing. That's all the computer does now with pap smears. At least in our country, they're not being read. They're being confirmed by humans, but they're not being read by humans. They're being read by computers. The computer will scan a microscopic slide, look at every cell, compare the size of the cell with the size of the nucleus, shine some light through there to see how dark the nucleus is, and then come up with a grading system, good, bad, or ugly. And that's as valid as the old system was. So it's a kind of a new world. And we have a group that will do this for oral cytology as well. But what did this group do? They called it a brush biopsy. It wasn't, I guess it was a brush. But instead of scraping, it really is, I don't know if any of you smoke a pipe or know pipe smokers, but it's just a pipe cleaner with a little twist on the end and a little piece of plastic to hold it. That's all it is. And yet the idea is to, instead of scraping along the top of a white patch, you just spin this right in, without anesthesia this is done. Spin it right into a white lesion until you see a little drop of blood, and then you know you're down to the bottom cells, the cells that are most likely, that's where the bad cells come from, remember? The bottom of the epithelium. Is it painful? Not really. I suggested one of our dental hygiene people in West Virginia University do a survey of people, hundreds and hundreds of people, who have this technique done and see whether they felt anything. And I think it was like 89% said, I didn't feel a thing. But that's your technique. You know, it's just like giving injections. Some of them hurt like hell, and others, the same exact injection doesn't hurt because of the hands, I guess, of the person doing the injection. So, but it's possible and very likely that there will be no pain, and there's minimal pain with this. So you don't even have to use anesthesia. The company called it a brush biopsy, and some of us, not our lab, but other, well, actually we are doing it now. But private labs or university labs have had to come up with a new name because of copyright patent infringement. So you'll see it under this terminology, and you know it's not the company that started the whole thing, liquid cytology or liquid-based cytology. And it really seems to work. Once you get those bad cells on the brush, then you send the brush off to the company. They spin it down in some liquid, spin the liquid, and then concentrate the cells and make a slide. And from that point on, it's like any other pap smear. So the only thing that's different is the way of getting the cells to the lab. Would that work on something like this? Not if you don't know the lesions. If you don't know that progression from left to right that I told you about, you might spin that brush right here instead of over here, or maybe over here. Or you wouldn't go into those rough surface areas. It really isn't made for a lesion that is obvious enough. It's made for those sort of iffy lesions like the thin leukoplakias. And it's been abused terribly. There was a dentist in Chicago who was doing 20 of these a day, just pushing it into normal mucosa and just getting the money from the insurance companies. So it's gotten a little bit of a bad rap because of this. But here, it's kind of a neat, logical explanation or way to get around a problem that came up back in the 60s that we couldn't somehow think of back then. I know we had pipe cleaners back then because I smoked a pipe then. So I don't think it would help. Your brain is going to have to tell you where to do the biopsy. You don't have any special help. But for those iffy kinds of lesions, it might give you a little peace of mind, at least for a while. And then this technique came along, using light. Because, well, I'll explain a little bit, but this particular light technique, the ViziLite, claimed that abnormal cells reflected much more the light that is hit. It's kind of a bluish light. And it has a few problems, one being that darn vinegar that I mentioned earlier. You have to swish with vinegar for a minute before you can use this light, because the little bits of protein that stick to the saliva on your mucous membranes, they give a false positive. So you swish with that. Another downside is you have to turn the lights off. And initially this was a chemoluminescence, a little tube of chemicals. You bend it a little bit and break a little glass barrier and the two chemicals, you shake them up, and you get light. Let there be light. We've all seen this now at carnivals and things like that. The kids use them for Halloween. And it's all depends, depending on what chemicals you use, you can get just the right wavelength. And this is the blue wavelength. So you shake it up, and now we have one that is electric powered, but same concept. Turn the light off and then look in the mouth. Of course, they had to leave the light on for the picture in this. And then if you see anything white, then record it. It's kind of funny because this is the drawing, exact drawing that I made up for my master's thesis in 1971. I gave it to the NIH, and so it's been public. It's not a copyright infringement, but I thought it was kind of cute that this is the drawing that they've been using. Well, they claim that the light goes down and only abnormal cells will turn out to be white. Unfortunately, that's not the way the light works. It only finds extra keratin on the surface. So you're only finding an area of whiteness, and maybe you would have missed, it might have been just barely visible gray or something, and this will make it look more white. And as it turns out, the vinegar makes it more white. That's a technique the gynecologists have used for years. They take a gauze soaked in vinegar before they biopsy a cervix that has a little suspicious area, lay it over the cervix for a few minutes, and then take it away, and the acetic acid makes the keratin more white. So the white is what they were looking for, just as we were. So that's really all this is finding, and I don't think it is scientifically sound. There are almost no studies, except studies that showed negative results with this. And I think it was just a company that thought it had an idea and was trying to get on a bandwagon, and it's kind of fading away. It has done one very important thing, though, in our country, and that is because they campaigned so hard that they made a lot of dentists aware of the fact that, you know, we have ways of looking for oral cancer, and we should be looking for oral cancer. So I can't really fault this company or the whole phenomenon, but it's fading away, and I think it probably should. These are the names of the electrified ones. And then this is what they did most recently. About a year and a half ago, they added, lo and behold, Toluidine blue. You put the vinegar in and then use a little swab to swab the Toluidine blue over the lesion, and then use the light. So if you see some Toluidine blue, then it will be okay. But I don't think you need the light for that. But this does, you see a barely visible white keratin here, and it does make it look more obvious. But it's only the keratin. It doesn't show, at least I can't figure out how it can show anything down below. And this is the Toluidine blue, same lesion. And this is how you get it on. So would that have been useful? I don't think the light would have been useful at all, because it would have shined on the keratinized areas, and those are the areas least likely to have bad cells. So, you know, why bother? Toluidine blue, if that was added, then it would have picked up, I think, some bad cells. And, but we knew that already from the previous discussion. This is kind of the latest and most scientifically sound concept. And it's based on the fact that we all glow. I know the advertisers talk about that glow after you take a shower or use a certain product, but you actually do glow. And there are certain there are certain molecules in all of us that are available to glow. They glow every time they're hit by a certain amount of light at different wavelengths. And bacteria have different kinds of light, and they glow at a different color and different rate. We glow at such a low level that we can't see that glow unless we use special goggles and really turn all the lights off. So you're probably seeing right now there's a downside to this technology as well, because at least in our country, all the operatories have one single light switch. So you're turning off the light switch to look in somebody's mouth, and you've just shut off business for the next 4 or 5 operatories. And so that's just not going to happen. So we're kind of having to fudge and keep the lights on in order to use this. But this is the one I think that has the most hope. I'm not sure we're quite there yet, but we try to get light in the blue spectrum. It's near infrared, not near infrared, near ultraviolet, really. And then the blue light, with the first product that came out, it's a Canadian company. Lots of good research. They got $15 million from our government to do their research. It's never happened before. A foreign scientific research project, totally funded in another country, and that's how much the NIH believed in this technology. Well, at any rate, the light is about a four-foot fiber optic cord, so you're kind of tied to it. And then it shines this blue light directly into the mouth. Some goggles are on, but not really necessary because this is very safe technology. And then the doc looks through the eyepiece and looks for dark areas. And any dark areas, the darker it is, then that means this is a cell that doesn't glow. And it turns out that immature dysplastic cells are the ones that don't glow. So this is an area, it's been FDA approved actually, for margins. They biopsied across the margin from the green to the black, and the dysplasia stops at that line. It's pretty amazing stuff, but there are still some downsides to this. And by the way, the Velscope company has just come out about 8 months ago with a portable product, so they no longer have you tied to that cord. And that's good because then you can go from operatory to operatory instead of lugging a 10-pound machine with you. This is another study. This came out of the University of Washington, I think, or maybe this is in MD Anderson. But there's what I would have called mild or thin leukoplakia, except that I'd be a little concerned that there are areas of increased whiteness, whereas thin leukoplakia should be fairly uniform in color change. And this is what it looks like with the Velscope. And this whole area, this was biopsied in 7 different places, and every place had at least mild dysplasia. Some of them were severe dysplasia. This test is now routine in a lot of endoscopic products for the GI, for the lungs, for the bladder, for lots of different things in medicine. And another example of, you've got some leukoplakia here, some fairly, I'd call it thick rather than thin. It's got some red patches, so where do you want to biopsy in this large lesion? I would just clinically say I would go over here. And that's where the darkest areas were, but there were some suspicious areas down below here that at least I would follow more closely and follow with the light itself. And another final example, just this sort of a whitish, grayish, fairly well-defined lesion that almost looks like a very thin skin graft. It's just a strange little thing, but you can see that the entire lesion was dark, and there again, I think there were about 5 biopsies done, and some of those had severe dysplasia. They all had some kind of dysplasia. And, well, we won't get into this. Toluidine blue does the same thing. This is what it's approved for. It's approved for 2 things by our FDA, which is, as I mentioned, under the gun from its citizens. They wanted to do a better job with devices, not so much the medicines, but devices. And so they have approved this for identifying lesions of dysplasia. It's actually approved for finding those. And here's a lesion. The surgeon just made a little India ink mark around it, and they took a picture. And then on the picture, they drew a green mark that covered the area that was dark. And there, I think this was 6 or 7 biopsies in this site. And this was, every one of them was dysplasia. So if this was in my office, I would have biopsied somewhere in here and totally missed the real area for the proper biopsy. So I think the problem is that we get too many false, not really false positives, but there are other things in the mouth that cut off the fluorescence, the normal fluorescence. This is one of these that I should mention, and that is, this is a gal who sold the Velscope, this device. She called me one day and said, "Do you have somebody with dysplasia? I've got about 15, 20 dentists who want to come and see this demonstrated." And I said, "Yeah, I think so." And I called one of our patients after getting approval from the surgeon. surgeon called her actually, well, she never showed up. It was moderate dysplasia. She never showed up, so we got 20 dentists sitting around in the dental school wondering what to do. And I said, well, why don't you just look at each other? And everybody was negative. We had some really pretty pink and orange colors from the bacteria on our tongue, but otherwise we were negative, except this 37-year-old gal who was the salesperson. And she grew up in Galveston and was out on the beach a lot, and she's already got these fairly deep vertical lines, sort of the beginning of a farmer's lip, and she's lost a bunch of the definition, the sharpness. See how sharp this is above? And you can't really see that over here. So she's got some sun damage. She's got some blotchy areas and some areas that are almost eroded and reddish. Well, we used it on her, and we found these 3 areas. And when we biopsied those 3 areas, this one had mild dysplasia. Well, this was moderate dysplasia. These had mild dysplasia. So here's somebody who she was thinking she was going to sell a product, and turned out she was the one with the problem. 2 problems. One is lichen planus. Lichen planus usually has a little red component. The epithelium is very thin, and it always looks a little dark with this technology. So you have to be able to use your brain again and look at the tissue and say, does this have a lichen planus look to it or not? And if it does, then you have a problem, because lichen planus is also a precancer, at least in many of our minds. So, but that I think you have to follow with routine, regular light. I don't think this is all that helpful for lichen planus. But I've noticed, it doesn't show up on the picture, but I can see, I've seen enough lichen planus with these devices now that there's almost a pink color to the background. Whether others can see that, I don't know. But I only see it with lichen planus, so I feel kind of comfortable with that designation. Sometimes this is eroded, or not eroded, but atrophic area and geographic tongue. I mean, that's a pretty innocuous lesion, but it can be very, very dark. And if somebody is rubbing their cheeks against their teeth or their tongue against their teeth, then you will get an increase in just not a real dark area, but an increase in loss of fluorescence. And of course, anytime you get blood vessels, remember that hemoglobin, it's going to absorb the energy, and you will not get any light coming back. And there are a lot of blood vessels in any inflamed area, so any area of inflammation, I mean, nicotine palatinus, I've already mentioned. We don't even think it's a precancer anymore. We've got inflamed salivary glands. They follow the pattern of inflamed salivary glands, so this is not something I would think of as suspicious. And certainly if you have melanin, it does the same as hemoglobin. It just soaks up the rays, and you get dark areas wherever there is melanin deposition. And amalgam will do the same thing. I don't know how that works, but it does. And the last problem, and probably the most frequent problem, is this. We all have these little bits of tonsil stuck all over our pharynx and posterior mouth, maybe the oral floor, and we don't see them normally. They're invisible. Somebody happens to come into your office when they're coming off of a sore throat. It's puffed up, it's a little bit red, and so now you can see it. And then you use a Velscope on it, and it will be pure black, very, very dark. So what you have to do, especially if you get a rounded look to it, you have to just use the regular light and go off to one side and another and try to get the three-dimensional aspect of it. And also this has almost a translucent look to it, where regular dysplastic cells would not do that. So there are ways of looking at it, but there again, you have to use your head. You can't just use the test to do your thinking for you. And the final thing is, on the Bouquot to Go disc, I have something called the 53 most common lesions. I showed you that. But now I'd like to show you another thing that is on there as a final thing for today. And this is something I put together fairly recently for our students in the University of Texas, because they get no oral pathology, which is the way I teach it, mostly clinical. They get no oral pathology until their third year Remember, we're all college grads, so the third year would be equivalent to your fifth year, I guess. And they're already seeing patients, so they could see an irritation fibroma, and they've never heard of an irritation fibroma, and we had to compensate somehow for that. So what I've done is in the spring of their second year, equivalent to the spring of your fourth year, we go over these kinds of lesions, and I've got a special set of them for sort of a self-evaluation. But I put together a listing called the must-know oral lesions. It's kind of the topic that I started out with this morning, the things you've just got to know about. You can't not know about this particular topic, even though it took a bit of time. But let's look at the must-know oral lesions just briefly. This is the first page you get to. Here are mucosal discolorations. This is, again, the way my mind works, so it seems to work okay for other people as well. Listing of the ulcers, blisters, pits, and fissures that we have to know about. And then the lumps and bumps, and then X-ray lesions, and then tooth lesions. So we've just talked about white lesions, the number one white lesion. Let's look at white lesions. And look at that. Remember I told you to call something leukoplakia? You've got to know every other white lesion. This is the short list of white lesions. So if you think you can get away with not being being a true professional in dentistry without knowing the oral path, oral medicine aspect of dentistry, think again. You cannot make a diagnosis of the most important precancer in the body, maybe in the mouth, but maybe in the whole body. You can't do that unless you know at least this short list. So this is on the Bouquot to go. So let's go to leukoplakia. Well, let's go to the latest one, actinic chylosis. This is the last page that we'll get to. You can see there's something missing. I have to write a paragraph for each of these, but everything else except for the breastfeeding keratosis is in there. And there will be clinical pictures, and you can look at this to see whether you've got some kind of a similarity to your lesions. It gives you a short list to think of, and then you only have to look for those short lists in the textbook. But this is designed to get you to the place where then you can do some real work, diagnostic work. So if you have a white patch, the first thing you have to look at is, are the margins sharply defined? And leukoplakias are almost always fairly sharply defined. And if they're not well defined, then there's a whole different list. Smokeless tobacco keratosis. So you use tobacco in one way, and you get a different list. You use it the smoked way, and you get a different list. And we've got quite a few lesions in both of those lists. And what happens if you get a mix? You've got white and red all mixed together, or white and pink mixed together. Well, the speckled leukoplakia, or the erythroleukoplakia is another name, red and white patch, is on that list. It's a very short list. Some of them are real easy to spot. Geographic tongue is something that nobody should miss, although a Norwegian physician last year sent me a whole bunch of pictures of his 8-year-old daughter saying, I'm really worried, I don't know what's wrong with her. And she was sticking her tongue out, and it was a classic geographic tongue. So that's another point that I really haven't made yet. You are the ones who know these diseases. The medical profession doesn't know, even leukoplakia. So, I mean, they know the name maybe, and that's as far as it goes. And then one thing you always have to keep in mind with white patches is does it slough off? If it doesn't slough off, then you've got to have it in one of these other categories. If it does, you've got a whole different list of things to think about. So this whole thing is, it gives you different kind of categories, different lesions, different colors, and I hope that it helps you out. Sooner or later it will be more finished. I'll have each of those little paragraphs finished. But it goes a long way to, I think, helping you at least get down to a manageable number of lesions instead of having to know everything for this one lesion in one patient.